First speaker this morning is going to be Jon Sussman in Manchester. So John, in favour of the motion, over to you.
Thank you very much. Next slide, please. Well, the answer is obviously yes, because it's what we've been doing. But if you don't agree with me, it's either because you want the old ways to continue, or because you argue about the figure of 80%. And who's supposed to decide what we're supposed to do in any case? So to answer these questions, we need to know what neurologists do in clinics anyway. We need to know whether clinics are the best way to diagnose and treat patients. But of course, Corona is the background to all of this. We have to be pragmatic. Next slide, please. So I've got a plastic surgery colleague who says that neurologists more admire disease than treat it. And maybe that was true in the past. Next slide. Clearly, neurologists find rare stuff interesting. So this is a correlation of frequency of diseases and publications. We write a lot about rare stuff. Next slide. But we've all got used to clinics. So who are they for? Are they for the doctors or are they for the patients? Is it fair to make a patient travel for hours without knowing whether they need a face-to-face consultation? Is it fair for a doctor to look at a referral letter, know the diagnosis, but not tell the patient for 3 months? And is it fair for patients to lose half a day's salary to go all the way to a clinic? Next slide. So in Manchester 15 years ago, we got the option of carrying out scans separate from the NHS. It was the way that the government was funding imaging at the time. So we set up a triage system to identify the patients who needed scans. And we realized that there was more we could do without seeing patients. And this graph just shows the outcome of sorry, I twitched, Georgina, shows the outcome of our initial triage. And what we showed without even trying was that 10% of patients can be given treatment without being seen, another 12% need tests before being given diagnoses, and 77% needed clinic appointments. And that was without trying to avoid clinic appointments. Next slide. So let's go back to the basics. What is health? So the WHO Constitution says that health is the highest achievable standard of health. Sorry, it says that the highest achievable standard of health is a human right. And they then go on to define health as a state of complete physical, mental, and social well-being, founded on an individual subjective perspective. So the next slide. So it's the individual subjective perspective. You as the patient decide. You're supposed to be in the driving seat as to what is and what isn't defined as health. So what we're trying to achieve is equity, not equality. Everybody gets the care they need to get health, not the same health, as this diagram demonstrates. So what do neurologists do in clinic? Well, a lot of headache, a lot of epilepsy and Parkinson's, and a whole load of rarer things. But on the whole, we're focusing on a small number of common conditions. And it's not that complicated. You need to exchange information between a patient and a doctor. There needs to be some kindness and good communication skills. And while we accept that it's a compromise, there's a question as to why the healthcare systems we work with have been the way they are at the moment. Now, for those of you who are not familiar, see, the woman at the top right-hand corner of your screen, Anna Rampton, is the director of Better at the BBC, and she doesn't understand what's going on around her. So she said, no, 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 nothing must change, because to change requires an understanding of what's going on. So what works and what doesn't work? Well, pre-COVID, perhaps a lot of the services are based on the convenience of the doctors and the hospitals. And we know that for neurology, 80% is history and 20% is examination. So telemedicine gives the option of a digital first approach. You triage, you then have a remote consultation and decide whether a face-to-face appointment is required. And we know from research that video consultations work well. The big question is whether we go for telephone or video, which is better. So, witness information is more likely to be available for patients with fits and faints if you talk on the phone. Another problem is patients who don't turn up to clinics. These are disadvantaged patients, and you're likely to get them on the phone. And of course, many neurology patients have poor mobility, so perhaps appointments are superior. Now, we know that a lot of patients don't have smartphones, so maybe telephone's fine. On the other hand, tremors are visual symptoms, and some patients require a physical examination. Now, there are costs to doing it remotely because some patients need a second appointment for an examination or for tests. So, final slide, read the question. Do 80% of patients, can 80% of patients be treated remotely? Well, yeah, they can. We've been doing it for the last 6 months and it works. But there is this element of the shock of the new. Now, I believe that the old system asked too much of patients and patients were disadvantaged as a result. And it's clearly been a success. We've managed to keep services ticking over. So the next stage is to define what services work best for the convenience of patients. And I believe that remote consultations are the answer. Thank you.
Thank you, John. That was really helpful, really